Hi everyone, my name's Johnny Old. I'm one of the current F2 doctors working at South Tyneside Hospital, and I'm going to give this talk on sepsis. So, the plan for the talk today is as follows. We're going to start off by just generally outlining what is sepsis. Why does it matter? Why do we care about it? Why do we need to know about it? How it should influence our practice. How do we recognise it? How do we manage it? And I'm going to touch briefly at the end on a particular type of sepsis known as neutropenic sepsis. So, what is sepsis? Officially, it's defined as shown on the screen, a physiologic, biologic, and biochemical abnormality caused by a dysregulated host response to infection. So what does that actually mean? Essentially, it's a whole body inflammatory response secondary to a localized infection. As we're going to come on to talk about, that infection could be anywhere. Common sources include chest, urine, and intra-abdominal. So now we've defined sepsis, we can talk about it as part of a scale. So down one end of the scale you have SIRS, so standing for Systemic Inflammatory Response Syndrome. So this is basically an exaggerated defense response of the body to any particular stressor. So that can be anything from something like pancreatitis, burns, trauma, and infection. And as I've previously mentioned, when SIRS is combined with infection, that is sepsis. That is the definition of sepsis. Further along the scale, you have what we class as severe sepsis, which is when you've got SIRS plus evidence of infection plus evidence of end organ damage. So this is when you might have oligoanuria, i.e. evidence of renal impairment. You might have altered consciousness level, i.e. evidence of end organ damage to the brain. And further along the scale, you have septic shock, which I'm going to come on to talk about at the later date. But essentially, that's previously aforementioned severe sepsis plus hypotension. So, now we know what it is. Why does it matter? Why should we care about it? Why do we need to know about it? So in terms of prevalence, how common is it? The answer is very, very, very common. These figures are from the UK Sepsis Trust website, just for clarity. They suggest that there are about 250,000 cases annually in the UK, which results in just shy of 50,000 deaths, so it's got quite a high mortality rate. I found figures that suggest it's directly responsible for about 5% of deaths in England, and that figure actually rises to just shy of 8% when you consider deaths that might have sepsis as a secondary cause. The Sepsis UK Trust says 80,000 people suffer from what they define as life-changing after effects. So this can be anything from long-lasting neurological impairment, potentially permanent renal damage resulting in dialysis after discharge, right the way through to psychological impairment, potentially from being in intensive care for a long time on inotropes, vasopressors, all that kind of thing. That might not seem like a lot, but obviously it's definitely worth bearing in mind in terms of the subsequent pressures that this can put on healthcare systems. A surprising statistic I found is that sepsis actually kills more than breast, bowel, and prostate cancer combined, which are three big killers in their own right. These three together are responsible for about 40,000 deaths a year in the UK, and as I've mentioned, there's about 48,000 deaths from sepsis. So that's quite a surprising statistic, I thought, and I thought we should put that in the talk. This is just a nice infographic I found actually produced by the World Health Organization. I'm not going to talk through it. I'm sure these slides will be sent out to you and you can have a look at this in your own time. And I think it's summarized as what I'm going to talk about in general in this talk quite nicely. And like I say, you can have a look at that in your own time. So in terms of recognizing sepsis, I think the first thing to mention is to always keep it in your head. Something along the lines of, could this be sepsis? As I've just talked about, it is very, very common and it does have quite a high mortality rate. Studies have shown that kind of early interventions, and to get the early interventions you need early recognition, massively improve patient outcomes. So I think just always having that in the front of your head is definitely a good thing to mention. In terms of the symptoms, obviously
Sorry, we're just going to start the presentation again in a few minutes. A few people still to join. So we'll start again in a few minutes. In the meantime, if you do have any questions, please do send them in. +44 333 303 0975 on WhatsApp. The QR code will be on the screen so you can send them in to us. So once again, please do send us any questions that you may have during today's presentations. The phone number is on the screen at the bottom, and join our Facebook page, www.facebook.com/SVJCUK. All the presentations from this week are live on the YouTube page, which can all be accessed via the Facebook page. And we'll be joining you with today's presentations in about 2.5 minutes. Once again, we'll be starting in just a few seconds. Any questions, do send them in to us.
Hi everyone, my name's Johnny Old. I'm one of the current F2 doctors working at South Tyneside Hospital, and I'm going to give this talk on sepsis. So, the plan for the talk today is as follows. We're going to start off by just generally outlining what is sepsis. Why does it matter? Why do we care about it? Why do we need to know about it? How it should influence our practice. How do we recognise it? How do we manage it? And I'm going to touch briefly at the end on a particular type of sepsis known as neutropenic sepsis. So, what is sepsis? Officially, it's defined as shown on the screen, a physiologic, biologic, and biochemical abnormality caused by a dysregulated host response to infection. So what does that actually mean? Essentially, it's a whole body inflammatory response secondary to a localized infection. As we're going to come on to talk about, that infection could be anywhere. Common sources include chest, urine, and intra-abdominal. So now we've defined sepsis, we can talk about it as part of a scale. So down one end of the scale you have SIRS, so standing for Systemic Inflammatory Response Syndrome. So this is basically an exaggerated defense response of the body to any particular stressor. So that can be anything from something like pancreatitis, burns, trauma, and infection. And as I've previously mentioned, when SIRS is combined with infection, that is sepsis. That is the definition of sepsis. Further along the scale, you have what we class as severe sepsis, which is when you've got SIRS plus evidence of infection plus evidence of end organ damage. So this is when you might have oligoanuria, i.e. evidence of renal impairment. You might have altered consciousness level, i.e. evidence of end organ damage to the brain. And further along the scale, you have septic shock, which I'm going to come on to talk about at the later date. But essentially, that's previously aforementioned severe sepsis plus hypotension. So, now we know what it is. Why does it matter? Why should we care about it? Why do we need to know about it? So in terms of prevalence, how common is it? The answer is very, very, very common. These figures are from the UK Sepsis Trust website, just for clarity. They suggest that there are about 250,000 cases annually in the UK, which results in just shy of 50,000 deaths, so it's got quite a high mortality rate. I found figures that suggest it's directly responsible for about 5% of deaths in England, and that figure actually rises to just shy of 8% when you consider deaths that might have sepsis as a secondary cause. The Sepsis UK Trust says 80,000 people suffer from what they define as life-changing after effects. So this can be anything from long-lasting neurological impairment, potentially permanent renal damage resulting in dialysis after discharge, right the way through to psychological impairment, potentially from being in intensive care for a long time on inotropes, vasopressors, all that kind of thing. That might not seem like a lot, but obviously it's definitely worth bearing in mind in terms of the subsequent pressures that this can put on healthcare systems. A surprising statistic I found is that sepsis actually kills more than breast, bowel, and prostate cancer combined, which are three big killers in their own right. These three together are responsible for about 40,000 deaths a year in the UK, and as I've mentioned, there's about 48,000 deaths from sepsis. So that's quite a surprising statistic, I thought, and I thought we should put that in the talk. This is just a nice infographic I found actually produced by the World Health Organization. I'm not going to talk through it. I'm sure these slides will be sent out to you and you can have a look at this in your own time. And I think it's summarized as what I'm going to talk about in general in this talk quite nicely. And like I say, you can have a look at that in your own time. So in terms of recognizing sepsis, I think the first thing to mention is to always keep it in your head. So something along the lines of, could this be sepsis? As I've just talked about, it is very, very common and it does have quite a high mortality rate. Studies have shown that kind of early interventions, and to get the early interventions you need early recognition, massively improve patient outcomes. So I think just always having that in the front of your head is definitely a good thing to mention. In terms of the symptoms, obviously going on from what we talked about at the start of what sepsis actually is, the main thing is a symptom of infection, and that'll be localized to wherever the source is. So obviously I'm not going to go into them all, but things like shortness of breath, productive cough for chest infection, dysuria, frequency for urine infections, they're the two probably the most common. And then other things like abdominal pain, you may be thinking kind of intra-abdominal source, or any other source for that matter. There are some kind of more generalized, non-specific symptoms that I thought it was worth mentioning. So things just like general malaise, just patients coming in, just saying they feel generally unwell. No, nothing quite specific. Can be a lot harder to pin these down, but it's definitely worth mentioning that there's just something not quite right here. Confusion there I'll come on to, but obviously changing consciousness now, this should start ringing the alarm bells immediately. Obviously you might be thinking a kind of intracranial event, but if that's ruled out, then maybe start thinking about other causes of that as well. In terms of the clinical signs, I've got there to check the news score. You'll have to forgive my ignorance. I'm not sure if you guys use the same or a similar scoring system. But if not, what it is essentially a score that's determined by just basic observations and parameters. The higher the score, the kind of more serious the situation in one thing. So you get kind of points, if you like, or score higher for if you're profoundly hypotensive, profoundly tachycardic, if your respirate's up, if you're febrile, if you've got a change of consciousness level, etc., etc. So it's quite a good, simple way of standardising it across the board, and can identify patients that are deteriorating. So it's really, really useful. Pyrexia obviously is a massive clinical sign. Should always be doing blood cultures, which we'll come on to when we talk about the sepsis 6. Obviously pyrexia can, not always, but if you see pyrexia you should be thinking infection obviously, and then subsequently is this sepsis, and do I need to kind of initiate the early management of that. Reduced urine output, so kind of whether that be from normally just from hypoperfusion of the kidneys, and a rash, sometimes presents with a rash, so just to bear in mind. In terms of recognising sepsis, two patient groups that I specifically want to mention, where the signs and symptoms might differ / might not be as obvious. First is the elderly. They might present with just general, more subtle symptoms or non-specific symptoms. I've mentioned some of them, but a particular example I wanted to make is patients with dementia. I've talked about confusion as a symptom of sepsis due to hypoperfusion of the brain. This is really obvious in patients that are normally totally compos mentis, go from totally normal to a bit confused, and you can pick that up really easily. But a lot of elderly patients have dementia or some form of other cognitive impairment, and a small increase in confusion compared to their baseline confusion might get missed, so it's always worth bearing that in mind. The other patient group is children. Children compensate really, really well, meaning they stay well or appear to be well for longer. They'll have lower news scores, and maybe only one of their observations might be out of the normal range. So they might have a slight tachycardia in normal observations otherwise, or an isolated pyrexia, and the rest of the observations are normal. But what happens is, because they compensate for so long, they can suddenly and rapidly decompensate and become, for example, profoundly hypotensive very quickly. So they can go from looking quite well to being very, very unwell in a very, very short space of time. So it's worth bearing that in mind when you're treating children, and potentially treating them earlier. So for your initial assessment, it is like any assessment you would do on any sick patient you see. It's A, B, C, D, E. I'm going to try and relate this specifically to sepsis. I know everyone has probably heard this to death, so I haven't got individual slides. I just thought I could talk through it. So A stands for airway. So is the patient talking to you? If they are, you're happy that their airway is paining and you can move on. If they're not, what you need to do something about it. So are they making any added airway sounds that suggest their airway might be compromised? Are they snoring, gurgling, things like that? Do you need to do a head tilt chin lift to open up their airway? Or do you need to think about airway adjuncts, something from an NPA, nasopharyngeal airway, or maybe an oral pharyngeal airway, otherwise known as a Goodell? If you're using a Goodell, make sure it's measured correctly from the incisors to the angle of the mandible. Or do you need to think about contacting critical care and asking them to come down and assess whether the patient needs a more definitive airway in the form of being intubated and an ET tube placed? But once you're happy that you've got an airway of one description and it's patent, you can move on to B, which stands for breathing. So here you can have a listen to the chest. Are there any signs of crackles, which might suggest the chest is a source of the infection? What's the respiratory rate? Definitely count the respiratory rate yourself. It's the most poorly recorded observation on a standard observation chart, probably because it's the one that it has to be manually done. There's no kind of machine like a SATS probe or anything where you can just read the number. It relies on someone actually counting the rest, so it's pretty subjective, and is often done poorly, which is a shame because it's also the best predictive value of a deteriorating patient. A tachypnea is often the first sign of a deteriorating patient. It's often the first clinical observation to go off, so definitely worth counting it yourself. Check the SATs. If they're hypoxic, give them some oxygen. Obviously, to be careful of over-oxygenating patients who have chronic lung disease, but definitely if they're hypoxic, then they'll need some oxygen therapy. Once you've found any problems and sorted those out in B, you can move on to C, which stands for circulation. Check the blood pressure. Are they hypotensive? Do they need some fluid replacement? Are they shocked? I'm going to talk about septic shock in a few slides' time, but obviously if the blood pressure is low and they're hypotensive, then you need to get some IV access, preferably 2 wide-bore cannulas, and start some adequate fluid replacement. Check the heart rate. Listen to their heart sounds. Is there anything that suggests that there might be more kind of rogue cause of the sepsis, potentially endocarditis? Do they have a new murmur that might suggest that? Send off some bloods, so specifically we're thinking full blood count, using E's, CRP, potentially LFTs if you're thinking of intra-abdominal source of infection, and also some blood cultures as well. Once you're happy that you've fixed any issues that you've found within C, move on to D. What's their consciousness level? The gold standard here is to do a full Glasgow Coma scale score, but failing that you can do a quick AVPU, so A, alert, V, responsive to voice, P, responsive to pain, or U, totally unresponsive. So it's a quick version of the Glasgow Coma scale that can assess a patient's consciousness level quickly. You can have a feel of their abdomen. Is it tender? Could that suggest an intra-abdominal source of infection potentially? Once you're happy that you've identified any problems within D and sorted them out as necessary, move on to E. So E stands for exposure. Is there any rash that might suggest an infection? Is there any erythema? Might suggest a cellulitis as a source of infection. Are they mottled? If they're catheterized, if you're seeing this patient on the ward, what's the urine output? We go normally by 0.5 mils per kilogram per hour as a normal urine output. So if it's lower than that, is that indicative of kind of hypoperfusion of the kidneys secondary to whatever cause? So following on from initial assessment, we've talked about A, B, C, D, E, specifically related to sepsis. If in doubt, get help. If you're like someone like me at my stage of training, that can be a more senior SHO, a registrar, or consultant. Hopefully there's always someone around to give you a hand if you feel like you need it. Then you're going to talk about investigations. So start with the basic stuff that you do at the bedside. We talked about observations. So do they have a tachycardia? Are they tachypneic? What's their blood pressure doing? Do you need to give them some fluid? What's their oxygen saturations doing? Do you need to give them some oxygen? What's the consciousness level, and are they febrile? Bloods we mentioned briefly in ABCDE, but specifically you want to do full blood count, specifically to look at white cell count and neutrophil count, likely to be raised in infection. Also using E's to get renal function mostly. This is particularly relevant when you think about what antibiotic prescribe and what dose to give, because some antibiotic doses change in renal impairment. You're going to want to do a CRP as well as a generalized marker of inflammation. And then there's other blood tests that you might think about depending on what you think the source of infection might be. For example, if you think it might be an intra-abdominal source, you're going to want to consider doing some LFTs. You might consider doing a procalcitonin if you're not convinced that this is a bacterial infection and you need something to help guide that decision. And you're also going to do blood cultures as well, which I'm going to talk about when I talk about the Sepsis 6 in the next slide. You're going to then want to look for a source of the sepsis. So common things are common. The two most common sources are chest and urine. So you're going to want to do a chest x-ray. Is there a big patch of consolidation there, which might suggest a pneumonia, and therefore a pneumonia is the source of the sepsis? You might want to send a urine sample for culture and sensitivity. You could do a urine dipstick in younger patients, but don't do a urine dipstick in elderly patients, as they're often positive anyway, and only treat a UTI in elderly patients if they have symptoms suggestive of the UTI. Still send the culture, because that can guide antibiotic therapy at a later period when it comes back. And then other stuff which is a little bit more advanced depends on the symptoms that the patient's presenting with as to what you might do to try and ascertain the source of infection. So that might be an LP if you're thinking about a nervous system infection, or joint aspiration if you're thinking of septic arthritis, or you might do an abdominal ultrasound if you're thinking about an intra-abdominal source of infection, etc., etc. Sepsis 6, this was something that I'm not sure who brought it in, but it's been around for a while now, and it's drilled into you from pretty much day one of medical school. Give 3, take 3 is what they always used to tell us. So in terms of give 3, give oxygen. As I said, chest sepsis is very common. Chest is a very common source, and patients will often be hypoxic because of it. So give some oxygen. Give antibiotics. Must give first dose antibiotics within the first hour of presentation. That's the gold standard. Often start as broad spectrum antibiotics. In our trust, we use chromoxiclav. I think other trusts might go straight to tazocin. But whatever your trust policy is, it's important to get that first shot of antibiotics in as quickly as possible, and to give some IV fluids as well. Sometimes these patients can present with hypotension, sometimes quite profound hypotension that isn't responsive to fluids, but you need to kind of try and fix that hypotension as best you can with fluids, and get some background fluid running after you've kind of stabilised the blood pressure a bit, / talk to critical care about potentially taking them for inotropes if needed. And in terms of the take of 3, so take blood cultures, especially if they're febrile. You should always take blood cultures even if they're not febrile. You don't always have to take blood cultures when patients have a temperature, but that can help guide antibiotic therapy at a later date. Make sure you try and take the blood cultures before you give the antibiotics. Measure the lactate. That's a really good indicator of how generally well perfused the organs are. The lactate's going through the roof. You're thinking that perfusion might not be brilliant, which can start ringing the alarm bells that this is getting really serious. Measure the urine output again as an indicator of how well perfused the kidneys are specifically, and that can give you an idea of how things are going as well. So it's quite an easy 6 things to keep in your head. Give 3, take 3. There's various mnemonics out there that might help you remember that, but I just remember the give 3, take 3, and it's pretty straightforward. So I mentioned septic shock earlier in the talk, which is basically when you get to the kind of final stage of that ladder that I showed you near the start, where you have SIRS, or systemic inflammatory response syndrome, where your body kind of overreacts to any kind of stressor, plus evidence of infection, and therefore it's defined as sepsis, plus hypotension, and that's when you're at the septic shock stage. So this is hypotension that is often refractory to adequate fluid resuscitation, and these are the patients that critical care should be contacted about early, if obviously suitable for escalation, for consideration of inotropes to help maintain the blood pressure and sustain organ perfusion. In terms of the causes, it can be immunocompromised patients, extremes of age, so children and elderly patients are more likely to develop shock, and it can also occur secondary to invasive procedures. The management is pretty similar, so I've just talked about the sepsis 6, you should still do that, and obviously it's management of the hypotension as well, so adequate fluid replacement, multiple fluid boluses is often needed, and as I've just mentioned, if suitable for intensive care, it's often worth getting them reviewed by critical care early for consideration of inotropes and blood pressure support. Yeah, that's basically what I've just said. Neutropenic sepsis, it's pretty self-explanatory in terms of a definition. Basically, sepsis, as I've already defined, plus neutropenia, so low neutrophil count. Why does it happen? Essentially, there's numerous causes, but the most common one we see is through secondary chemotherapy. So patients will be having chemotherapy for whatever malignancy, and subsequently are immunosuppressed and have a low neutrophil count. Then they get an infection which their body can't fight off because they're immunosuppressed, and that kind of accelerates the sepsis process, and these patients can decompensate faster. and therefore it's really important to get these patients given antibiotics as quickly as possible. I mentioned previously about early recognition, where it's particularly vital in this patient group. The symptoms can be atypical, so you can consider empirical antibiotic treatment earlier than you might do in other patient groups, just to be on the safe side. You can also consider giving GCSF on hematology advice as well, something that will hopefully stimulate bone marrow and produce more neutrophils, which can aid fighting off the infection. That's it, guys. That's my talk. I appreciate that was quite a quick run through, but I try to keep it simple and relevant to clinical practice rather than going into depths into the pathophysiology and everything around that. So hopefully it was useful, especially for anyone that's kind of at my stage of training as well. Thanks for listening. If anyone's got any questions, feel free to email me. That's my email address. Thanks very much. Bye.
Hello and welcome to your critical care session day as part of this teaching week. My name is Dr. Ryan Ellis. I am an anaesthetic trainee based in the UK. I'm very happy to be here today and invited to teach on the topic of management of AKI, or acute kidney injury. Of course, this is in relevance to critical care, and I am not a nephrologist, so we won't go into exact details of some pathology, but we'll be highlighting some of the important points related to the critical care of this pathology. So the first question I feel we need to ask, considering we are coming at this topic as intensivists or anaesthetists, and not as internal medicine or specifically nephrologists, what is the importance of this topic to us? And I think it's very important to simplify this down and then break it down further into points that we can really appreciate and tackle. To really see the importance of this topic to intensive care medicine, the first place to start is to really break down what intensive care medicine is. And you really, when you have these complicated topics, it's great to start at a very simplified point where we can then expand our viewpoint going forward. So where I like to start is, if I'm working in the ICU and I'm getting referred a patient, what do I expect to see? What I expect to see usually comes, and of course there are always going to be outliers, but I usually see patients falling into these broad categories. Someone with a low GCS not protecting their airway, and I'm asking, do they need intubation? Someone with respiratory failure, that's something we've certainly seen a lot of recently. Again, do they need intubation? Someone who's got low blood pressure, do they need vasopressors? And the fourth category is the one that we're thinking about. A patient with severe acidosis or renal failure, I'm thinking, do they need dialysis? Do they need renal replacement therapy? So in each of these categories, we're thinking about the organ support beyond the ward-based care that a patient will have, the higher level organ support that we can deliver. And it's that fourth category there in bold when we're thinking about renal replacement therapy. That is where AKI becomes important to the intensive care medicine, and it's the importance it is to us. So that is why we need to consider it, think about what causes it, think about what the management strategies are, and definitely think about where the urgency lies. So if we're going to tackle it and manage it, first we need to identify it. And there are some numbers we can use to define AKI. These are outlined below, and again, they're not absolute, and you may have some more local parameters that you go by, but here's some examples of definition according to the Kidney Disease Improving Global Outcomes guideline. And these include the use of creatinine and the use of urine output, which is displayed there. So these are some numerical values you can use for the basic ward definition of an AKI. So the previous slide outlined some specific parameters set by the guidelines mentioned. There are some more broad-based definitions that you can use clinically as an idea that the renal function has become inadequate. And when we say inadequate, remember at the back of your mind, the point is that it's become inadequate to clear waste products and metabolism. And this will give you an idea of what you're looking for. Some of the suggested features that you can find clinically and both via the laboratory include uremic symptoms, which involves drowsiness, nausea, twitching as some examples. raised plasma creatinine, as we've already mentioned, also hyperkalemia and hyponatremia, and metabolic acidosis, features that could be identified on a blood gas, for example, both arterial or venous. So now we know what AKI is, and we know how to identify it, and hopefully by now we have accepted the importance of it, otherwise the rest of the slides won't matter too much. But now that we know what it is, it's very important to always make an effort to identify it early. And it's the prevention of AKI, or the prevention of worsening kidney function, that we always need to think about. And you must place exceptional importance on the avoidance of any factors that contribute to AKI, nephrotoxic drugs being one example. But there's multifactorial insults that occur. You have to try and minimize them as much as you can to prevent the initiation of an AKI or its worsening. Because AKI is very common in critically ill patients, and it can result in long-term morbidity and mortality, even after the short-term recovery. And in the recent NICE guidelines, it's actually mentioned that it could be preventable in 20% of cases where you have AKI recorded. So whenever there's any suspicion of AKI or any suspicion of factors that may result in AKI in a critically ill presenting patient, then you have to do what you can to tackle all the multifactorial issues that will contribute and reduce the risk as much as you can. And that is always the first stage. With all that being said, it would now be nice to focus on the causes of acute kidney injury. However, that focus is not going to be particularly narrow, as we've mentioned already. This is a multifactorial problem, particularly in the critical care setting, with many different etiologies. And as we said earlier, we're not nephrologists, and we're not going to go into the details of every different cause. But it's important to be aware of the different insults that could be occurring to result in acute kidney injury, and to think about the general support that we can give, the general treatments that might be needed, which we'll come on to in a minute. So before we go on and think about some more general ways of supporting patients with acute kidney injury, I thought it would be nice to first mention some specific causes that are important to think about. Because occasionally AKI will have been caused by conditions which require specific treatments, and you must ensure that you've thought about these and any alternative approaches beyond the general supports that we'll be talking about later. Some of these specific treatments, and this is not an exhaustive list, are outlined here below, and they include immunosuppressive drugs, which may be important in glomerular disease, for example, plasma exchange or interventional radiology. And when you're thinking about what general treatment support you might need to give, do extend your mind to think about any specific causes and any specific treatments you may need, for you do not want to delay these. So one further specific scenario that I wish to highlight, which is certainly important to us if we're coming from an anesthetic and surgical point of view, is the post-operative renal failure. Now, when the patient comes to us in theatre, particularly in an emergency case, we must always think about the risk factors involved. And here are some risk factors, again, not an exhaustive list. The risk factors we need to be thinking about to prevent, and again we come back to that key word that we've already seen and mentioned, preventing AKI, or certainly ensuring that it's not too significant or severe. And some of these factors may include hypovolemia, and maybe the patient needs some pre-optimization, for example, more fluid therapy before their theatre. Thinking about hemodynamic instability, both before and especially intraoperatively. Thinking about the age, so the patient factors themselves, and thinking about all those different cofactors that we've repeatedly mentioned, and for example, sepsis. We also want to be thinking about the surgical procedure itself, and are there any risks? Here I've mentioned any surgical procedures that may damage the lower urinary tract and lead to obstruction and post-renal failure. Now, this could be gynecological surgery, for example, would be an example here. Another surgical procedure may be interventional radiology or anything that requires nephrotoxic dye. And then the last example I've given is thinking more about the vascular side that may lead to renal failure. And here I've highlighted abdominal aortic aneurysm surgery and the risk of renal artery disruption. So you can see there are many factors, patient factors, both innate to the patient or those that are relevant to their presentation at the time, and the surgical factors as well. So following those examples that we've given of some specific instances that may cause AKI and some specific thoughts to have to treat and indeed prevent AKI, here now is a basic outline of some management we may wish to give to any patient who presents with this syndrome. So things that we need to focus on are correction of hypovolemia and hypotension. This may involve, of course, fluid therapy. It may be all you needed. Prevention of additional renal insults. And this is thinking about all our cofactors and all the different insults that may be inflicting themselves upon the renal system. This could be drugs, nephrotoxic drugs, or sepsis. And this will lead into our next cause, the treatment of any underlying disease that is present. And it's important to note that the use of diuretics should be limited to patients with fluid overload who are waiting to start renal replacement therapy, or those whose renal function is recovering following an episode of AKI. So those are some general principles that you can apply across the board really when you're thinking about a patient who's presented with acute kidney injury. But again, you're always thinking about what the causes may be, and these causes may be multiple. This list that I have here may need to be applying more than one of them. And in fact, in critical care, most likely you will need to apply more than one of them. We can think about them one by one, going down the list. You can think about urinary tract obstruction. So at this point, you may have to decompress the lower urinary tract that has been obstructed, perhaps with a urinary catheter, or if that's not sufficient, you may decompress the ureteric obstruction by nephrostomy or stent, requiring surgical intervention. You need to think about hemodynamic management. So we've already mentioned in the previous slide how generally you need to correct hypovolemia and hypotension. So this is the important point of focus with the hemodynamic management. The circulating volume must be corrected first. So prompt restoration of the circulating volume, and then this could be followed, if required, by any necessary inotrope or vasopressor to support or maybe even reverse pre-renal failure. Then we have urgent treatment of hyperkalemia. Now, this is a very important one, which of course you should not miss, and it was mentioned previously in some of our causes. And this would be just a general management strategy for acute treatment of hyperkalemia. Then we think about metabolic management. Now, a lot of metabolic management will fall under the final category of renal replacement therapy. There are many things you can do via a central peripheral line to replace deficiencies in sodium, calcium, phosphate, and even metabolic acidosis with the use of bicarbonate if required. Now, as we mentioned at the top of this talk, if I'm referred a patient with AKI and I'm in critical care and I'm thinking about what to do with this patient, my mind will go through all that we've spoken about. What could be the possible causes? What could be the possible factors, multiple factors, any specific treatments that may be needed, any general treatment that is required. Looking at this targeted list, do they fall on any of these? And finally, if all this list that we've gone through has been tackled and managed, and the patient still requires our help, it's most likely because they need renal replacement therapy. And that is where the critical care side of things really comes into play. Now, as I did at the beginning of this talk, when I tried to break down what ICU is and the service delivery via some simple questioning of what we deliver and why, I'm going to do the same here. Renal replacement and dialysis is quite a complicated subject, and to go through the whole thing will take a significant amount of time, and I will not blame you for leaving this talk immediately if I was going to the nitty-gritty details of it. So what's important is to highlight what we need to know from a critical care point of view. And these are the questions that I think are important when I get referred a patient who might require renal replacement therapy. What I want to know. I want to know what it is, who needs it, and most importantly, do they need to go on it overnight? So let's begin with what is it? which seems like a good place to start. Now, what is it? To put it simply, dialysis or renal replacement is simply a process that takes over the job of the failing kidney. To do the jobs that we've already mentioned it does. Get rid of toxins, excess fluid, and the regulation of electrolytes. So that's simply all it is. Now, it's very important to understand the difference between what a patient would, with established renal failure, the dialysis they have, compared to the acute patient that we might receive in critical care. Now, patients with established renal failure are on intermittent hemodialysis, usually 2 to 3 times per week. This involves taking a large volume of blood through the dialysis circuit, removing toxins, replacing electrolytes, etc. And these sessions usually last 3 hours. And because lots of blood is taken and dialyzed, the patient needs to be hemodynamically stable to achieve this. However, when we're receiving these acute patients to critical care, well, if they're coming to us, by definition, they are critically unwell and they are unstable. And they won't be able to deal with this large load of fluid taken off. So, for example, a dialysis patient may come to critical care with a blood pressure systolic of 80, diastolic of 40, and such a patient will not be able to tolerate taking large quantities of blood out of an already struggling circulation for the purpose of dialysis I've already described. But they will need to be dialyzed somehow. The solution is to dialyze them at a slow, steady rate rather than trying to fit it all in 3 hours, as this causes much less hemodynamic instability. So this is where the feature of continuous veno-veno hemodialysis comes in critical care. We use it in sick, hemodynamically unstable patients where intermittent dialysis would not only be poorly tolerated, it could kill the patient. So now we know what it is, we need to think about who and when. So who are patients who present with the following pathologies in the list below, which I shall go through in more detail in a second. And when, this list are the urgent cases. These ones need to be dealt with without delay, with immediate critical care input to deal with the renal failure and the subsequent issues that we'll see here. Otherwise, they may lead to significant deterioration. So let's go through these urgent cases together. So firstly, hyperkalemia. We've already met hyperkalemia on our journey, and this is something which should always be considered and dealt with, as we've seen in our general management. But here we're really thinking about refractory hyperkalemia. It's that hyperkalemia that is very high and remains elevated despite maximal medical treatment, especially if there are ECG changes as well. Okay, so you should always think back, if you see a patient with hyperkalemia as mentioned, it needs to be monitored very carefully, and if it's found to be refractory, medical care may have reached its ceiling, and this is where we need to bring in our renal replacement therapy. Next is severe metabolic acidosis, and there is no absolute parameter here. You may have local parameters which you may need to go by, but generally it's thought of as pH less than 7.2 and or very high lactate. Now this pH less than 7.2, I'll come back to why that is important in the next slide, so keep that in mind. Next, again, we're looking at refractory severe fluid overload, more specifically pulmonary edema, and this is when it does not respond to diuretics with worsening renal function. Severe uremia, and we've already mentioned uremia and some of the symptoms you may need to look out for there. And severe drug poisoning and a dialyzable drug, and there are a whole list of these you could look at. An example that I've seen regularly is salicylates and overdosing with that drug. So these are things, if you have any of these on your list and they are not able to be managed medically, these are urgent cases which you need to deal with in the critical care setting with renal replacement therapy. So I've just added a couple of slides, some clinical pearls, some wisdom, some information that helps us understand what's going on a bit better. So if you come back to that point I made earlier about severe metabolic acidosis, why is that occurring and why is 7.2 important? Well, firstly, why is it occurring? So the kidneys are responsible for the filtering and reabsorbing of bicarbonate. And so the failing kidney cannot retain this bicarbonate, so we have low levels of bicarbonate, and hence there is metabolic acidosis and acute renal failure, so the fall in pH. Okay, so we can deal with that. However, one of the reasons that the pH 7.2 is picked, as I mentioned earlier, as a marker of severe metabolic acidosis, which may require further intervention, is because at this low pH, inotropes and vasopressors are less effective. So if we're requiring inotropes and vasopressors, which we may well be needing to in a critically unwell patient, if we can improve the patient's pH, we can also improve the response to vasopressor therapy. Okay, so we're addressing multiple different factors here in one go. So this is why 7.2 is important in the context of renal failure and metabolic acidosis, particularly if you're also requiring vasopressor support. Continuing who and when, here are some more who's, some more examples of pathology requiring renal replacement therapy, and also when, perhaps, and again, always take each patient in context, it's perhaps less urgent than the previous list. So we can think about uremic encephalopathy or coagulopathy and severe sodium disturbance. Now, this is hypo or hyponatremia, and I want to come back to this point in the next slide as well. The next point is hypothermia. Now I mention this for a particular reason. So firstly, hypothermia itself, by taking blood out of the body, it naturally becomes a bit colder than body temperature. So this is why, or how rather, you can use dialysis to treat hypothermia. But the more important point here is to appreciate that fact that I mentioned, that taking blood out of the body naturally makes it become a bit colder. So whenever a patient is on dialysis, hemofiltration, any low-grade pyrexia, and especially temperature spikes, should be taken very seriously, as the true temperatures are likely even higher than that, as the circuit is making the temperature artificially lower. So if you have a patient that's on the circuit getting artificial renal replacement support, really pay attention to any spikes in temperature, as the body should be cooled by the process. So if you do have these spikes in temperature and pyrexias, this really is a sign of sepsis developing. So take those very seriously. There's a further list of things to think about. We'll just mention more on sodium next. So this is the second of our clinical pearls that I just want to mention. And as sodium can be particularly confusing most of the time, I just wanted to highlight it further here. So we know that we can use our dialysis to regulate and correct our electrolytes. And in this context, we're thinking about hyponatremia. And if we have significant hyponatremia, so somewhere way below 125, we really need to be careful about the rate at which we correct that sodium, as the same general rules of correcting sodium apply here as well. And you do not want to correct sodium too quickly. So you need to dialyze them at lower exchange rates so that sodium correction isn't done too quickly with the relating consequences. So, of course, what that means is that all the other things we're trying to remove, toxins, etc., will take long to remove. Okay, so we just have to put up with that and deal with a slower correction for the sake of not allowing sodium to correct too quickly. So that's an important point to consider when you have your significant differences in sodium as well. Many thanks for your attention. That was, I hope, a clear overview of acute kidney injury in relation to the critical care setting. We've covered, hopefully, why it's important to our setting, thinking about some of the definitions and identifications, some of the causes, specific and general management, and then going on to think about dialysis hemofiltration in particular and the urgencies and settings for the application of that process. So thank you very much again.
Okay, we'll be starting again in a couple of minutes, about 30 seconds. If you have any feedback, please do use that QR code on the screen. Let us know, it really does help us. Also, if you do have any questions, please send them in. It might take a little while to get back to you, but we will get back to you with any answers. So we're going to be joined now by Claire, who is our specialist nurse in organ donation, who will go through organ donation in the UK.
Hi everyone, my name's Claire. I'm one of the specialist nurses for organ donation here in the northeast of England. I'm going to talk to you a little bit today about diagnosing death using neurological criteria, which is more commonly known as brainstem death. I'm just going to share my presentation with you. There we go. So as an organ donation team, we get involved in nearly all cases where neurological death is being considered. So our ITUs and our A&E departments all know how and when they should refer to the organ donation team. So for any patient where there is a plan to withdraw life-sustaining treatment, so these patients normally on a ventilator, and although we do DCD donation here in the UK, so donation after circulatory death, or what we used to call non-heartbeating donation. I know it's not common practice in India, but it's very usual practice here in the UK. They also refer any patient where they plan to perform neurological death tests. And if a family bring up donation, it can often be useful to get the SNOD there to answer any of their questions in a timely manner and to know that they're getting the right information. The units contact us via a pager system, and that pager is manned 24 hours a day, 7 days a week, so we're always available for advice and support. The benefits to referring to the SNOD team early means that we can do a quick assessment of anyone considered to be a marginal donor, so that's taken into account the patient's age, if they're of older years, and if they've got a lot of past medical history, and their current status with regards to their current blood results and function. We can check the organ donor register, and that lets us know whether they've registered a decision to donate or not, and that means we can assess their donation potential. It's worth pointing out that although we talk about organ donation a lot more now than we used to, of all the deaths that happen in the UK every year, only 1% of patients, of people, and that's community deaths as well as hospital deaths, die in circumstances where they fit the criteria for referral to the organ donation team. So being a potential organ donor is still quite a unique situation to be in. Calling us early means we can get the organ donation nurse on their way, so they can either be on site or at least on their way to support the unit and the family. We can often help identify and support in resolving any coroner's issues and that referral. Involving us with the clinical team means we can plan how we're going to approach the family and how to support the family through the neurological death tests. And it gives the unit opportunity to have clinical advice and support from ourselves, often not just about donation, but in optimising for the tests themselves and ensuring that the tests are being done properly. The conditions that can lead to neurological death include traumatic head injuries, intracerebral hemorrhages, anything where there's real inflammation, so meningitis, encephalitis, infarctions, severe cerebral anoxia, more commonly hypoxic brain injuries following cardiac arrest. But basically any condition that can cause the brain to swell uncontrollably can lead to neurological death. And how does it happen? Well, the brain, the skull, is a fixed box, if you like. So if we put extra swelling, bleeding or injury to the brain within that box, it then gets compressed against the skull. There is only one outlet, and that is downwards through where the brainstem comes and where the spinal cord and blood flow comes into the brain. So when the brain is pushed down in that area, it then gets squashed and it cuts off the blood supply to the brain. No blood supply to the brain gives us no oxygen, and we know we only need to have no oxygen for a matter of minutes and it starts to die. The brainstem controls consciousness, the ability to breathe, our heart rate, our blood pressure control, and even some hormones. It's really important to be able to recognise when neurological death may have occurred. So patients will have fixed pupils and they may be dilated, but not always. They'll have no cough, no gag. There'll be an absence of breathing. They may have had large volumes of urine output because they've developed some diabetes insipidus, and they often have cardiovascular instability, but not all do. And the photos on the right are just the photos from a monitor and a ventilator of a patient where the nurse was telling me about the patient and confirmed that he had fixed dilated pupils, he had no cough, he had no gag, they were getting no responses at all, but he was breathing on CPAP, so therefore he couldn't be brain dead. So I asked the doctor if he would take him off the ventilator because he was on CPAP, and the consultant is saying, no, this patient must be breathing, he's got good tidal volumes, he's on CPAP, so he's breathing for himself, he's got good respirations, he can't be brain dead. So we took him off the ventilator and there was no attempt to breathe. He put him back on the ventilator, back on CPAP, but then turned off the assist, so there was no assist, no PEEP. And you'll see from the green numbers at the top, the patient's heart rate was 75, and then circled on the bottom photo is the spontaneous respiration rate of the patient. So simply put, the CPAP, the ventilator, has been picking up the patient's heartbeat, thinking that's the patient trying to deliver a breath. So the point here is to remember to look at your patient, not just your monitors. Now, all being well, we've been able to put a video in here that talks a little bit more about explaining neurological death to families.
Explaining the death of a patient to their family is a very difficult and humbling experience, and one for which traditionally there has been little training. Explaining to families that the person they love has died, while still on mechanical ventilation, while still warm and with their heart still beating, is even harder. This can be a confusing concept, even for healthcare professionals who work in intensive care. We have all stumbled during these challenging family conversations, and you can find yourself using terms such as essentially dead or legally dead, as if there are different states of being dead, or stating, wrongly, that it is only the machines which are keeping them alive. If we struggle, is it any wonder then that the public can be confused? A survey carried out in Northern Ireland in 2013 found that nearly 50% of those surveyed thought that maybe you could, or they didn't know if you could, recover from brain death. This misinformation is no surprise, given that media reports frequently confuse persisting coma with brain death, and even the BBC will report brain dead man dies in hospital. It is for this and other reasons that in the latest Academy of Medical Royal Colleges Code of Practice for the Diagnosis and Confirmation of Death, the terms brain death and brainstem death were abandoned. Instead, the Code of Practice simply talks about the diagnosis of death. Recommendations in the Code outline the different criteria doctors should use to diagnose death, either by circulatory criteria or neurological criteria, depending on the clinical scenario of the patient. In this guide, we are covering the diagnosis of death using neurological criteria. But how is this best explained to families? There is no perfect answer, as the individual circumstances, family expectations, and clinician personalities will all play their part. I find that an ABCD approach has served me well clinically over many years, and a similar framework can be helpful when explaining the diagnosis of death using neurological criteria to families. A is for accuracy. Be truthful about what you know and what you don't know. This is more difficult than it sounds. Obviously, one always wants to be accurate, but what can get in the way of accurate communication is poor planning, and this can lead to muddled messages. Take the time to plan the conversation with the bedside nurse and with a specialist nurse for organ donation, even when donation is not yet a subject ready to be raised with the family. This will allow the clinical situation to be accurately clarified and serve as a rehearsal for the words you're about to use. Planning also allows common themes for good communication to be considered, such as the setting for the conversation, the chair layout, and who needs to be present, both from the clinical staff and from the family. Accurate explanation of the diagnosis of death using neurological criteria can be achieved if you keep sight of the essential message we want families to understand and accept. That is, that death is suspected, and that there will be tests carried out to confirm or refute this suspicion. A good way to check and support family understanding is through the deliberate use of summarising moments. This is particularly useful if there's been a long monologue of information giving, or a new topic is about to be introduced. Watch the family's reaction carefully when you summarise. When the family do ask questions or make statements, always acknowledge and reflect on what they have told you. B is for brevity. It is known that during times of grief, thinking slows. It is very important that the pace of the conversation slows to meet the needs of the family. Silence is an essential tool to help achieve this. Do not fill the silence with your own voice. That time is for the family. Long silences can sometimes feel very uncomfortable for the clinical team, but this conversation is about helping the family understand and accept their loss. It's not for our benefit. A good rule of thumb is that after any major statement of fact, for example, when you explain that the patient has died, this should be followed by silence. This will allow time for the devastating news to be processed by the family and allows them the opportunity to ask questions. The more you talk, the more likely the accuracy of your message will be lost, the more likely that confusing terms and concepts will slip in, and the less time the family will have for achieving understanding and asking the questions that are important to them. C is for clarity. As doctors, sometimes we just assume that after we have spoken, everything is perfectly clear to the family. In the conversations we are talking about, the bedside nurse and the specialist nurse for organ donation have an important role in continuing the conversation with the family long after we have left the room. That is why it is so important for them both to be present for our family conversations, as this allows them to build on and explain further, if necessary, our messages. What we can do to help ensure clarity in our communication is use simple and unambiguous language, avoiding technical and medical jargon. It is important that at some point the word death or died is used, rather than euphemisms such as passed away. This helps families to understand the essential message, that the tests are being undertaken to confirm if their relative has died. The use of visual aids can be extremely helpful, especially as some people are more visual learners. This can be achieved by showing the family the CT scans or by drawing diagrams. The James Cook Hospital in Middlesbrough have a relatives information leaflet that they give to families to help aid their understanding. One of the most powerful ways we can help clarify the diagnosis with the family is by allowing them to witness one of the two sets of brainstem tests. We would recommend the second set of tests as ideal for this. This will also demonstrate your profound transparency and openness to the family, which can help facilitate their trust in the diagnosis of death you are delivering. D is for delivery. The style of your delivery will be very personality dependent. Nonetheless, it is the tone of your delivery and how you made the family feel that is more often remembered by families rather than the words that you use. A doctor who can be accurate and clear, as well as being sensitive and empathic, will long be remembered positively by the family despite their tragedy. 3 simple suggestions can help. I've already spoken about the power of silence. Good use of silence and allowing the family the opportunity to talk will go a long way in letting the family know that you are listening and working to their pace, not yours. It's okay, and it's right to say that you are sorry for their loss. This is not an admission of wrongdoing, but a simple human acknowledgement of their grief and a way of expressing your sympathy. You will deliver your message more effectively when you work within a multidisciplinary team. Allow the bedside nurse and the specialist nurse for organ donation to support you. They can be picking up on and ready to respond to the non-verbal signs from the family that you may have missed as you concentrated on the words you were saying. But even after watching this video, always be yourself and always be genuine. This level of honesty and openness can be personally very challenging. But remember, the key transaction that is occurring between the family and you is not knowledge transfer, but the transfer of trust. The family, even if they witness the tests, will not become experts in the diagnosis of death using neurological criteria, but they should be able to trust that you are.
So before we go on to perform the tests, we need to meet certain preconditions and make sure that this is the right thing to do. So we would need evidence of an irreversible brain damage of known etiology. So that traumatic brain injury or that intracerebral bleed, and that will normally have been confirmed using a CT scan. We also need to make sure that the lack of breath and the deep coma the patient is in is not due to any drugs that the patient has either took prior to admission or anything we've given them, perhaps due to sedation. And we'd also be checking the patient's temperature, blood pressure, MAP, metabolic, the blood gases, and making sure that the blood results are all within the required parameters, because things like a sodium being way too high can also affect response. Our form also has some red flags highlighted on it, and it's just to give us some caution around when we do the tests and whether or not any of these circumstances may be present. So we wouldn't routinely do any brainstem tests within 6 hours of the loss of the last brainstem reflex. And we would wait 24 hours if that loss of brainstem reflex has been due to primarily anoxic damage, so most often a hypoxic brain injury following a cardiac arrest. If the patient has been cooled and has had hypothermia, we would therefore not test until the patient has had normothermia for 24 hours. We advise caution with patients with neuromuscular disorders, if steroids have been given in space-occupying lesions, if there's been prolonged fentanyl infusions, or if the etiology is primarily located in the brainstem or the posterior fossa. And we have a new one there, number 8, therapeutic decompressive craniotomy was added just last year to our red flags when we had an 18-year-old gentleman in the south of England wake after having his brainstem death tests completed. So we're not saying that you can't test at all if these are present, but we're just adding some more caution. I had a little look to see if the tests are done very differently here in the UK compared to how you might do them in India. And I have found an article, I've been given an article that does show us what physical tests you do when it comes to performing the tests. And I've put 2 little red crosses next to the reflex tests that we don't do here in the UK. So we don't do the oculocephalic reflex, often called doll's eye phenomenon, and we don't do a vagus nerve function test either. So we don't do the atropine challenge, but everything else is pretty much the same. We've got a video here now that shows two of our consultants actually performing the tests on a real patient whose family have very kindly given consent for this to be recorded. The patient unfortunately didn't go on to donate, but the family feel very much that even this video as an education tool has been his legacy.
When both doctors are satisfied that the preconditions have been met, they are able to move on to the next stage, the clinical examination. The tests, examinations of brainstem reflex activity, provide information about the integrity of the brainstem at various levels and should be conducted by the two doctors working together. The Code of Practice directs that the tests must be carried out twice and wherever possible by the same two doctors, one performing the examination on the first occasion with the other observing, and then switching roles for the second set. There is no time interval specified between the two clinical examinations, other than that required for physiological stability to be restored after the apnea test. Some doctors use the period between the tests to talk to the family. Families are increasingly being invited to observe the tests being performed, most typically the second set, and they should be warned of the possibility of spontaneous and reflex spinal movements. We will now go through each element of the clinical examination in more detail, working in a craniocaudal direction and starting with the pupillary light reflex. There should be no pupillary reflex response to light. The pupils should be fixed with no direct or consensual response. Note, there is no requirement for the pupils to be the same size or the same shape.
Do you mind turning the lights down?
The test should be undertaken in a darkened room using a bright light
In
source.
both eyes and looking for a lack of reaction.
It may not always
eye.
be possible to examine both eyes because of trauma or previous pathology, but at least one eye should be
And there's
accessible.
no direct or consensual response.
No, there's no reaction.
Next, we go to the corneal reflex. The corneal reflexes should be absent bilaterally with no blink following stimulation of the cornea with sterile gauze or saline eye drops.
Okay, so you're just going to feel a little...
Note that any contact lenses should be removed before conducting the examination,
No corneal reflex.
and that it is the cornea, the coloured part of the eye, and not the sclera that should be stimulated, as the cornea is more sensitive. Care should be taken to avoid damaging the cornea when performing the test.
On the left-hand side.
There's no reaction.
We now examine whether there is any motor response within the distribution of the cranial nerves to a centrally applied painful stimulus, for example, supraorbital pressure.
So you're just going to feel a little bit of pushing just above your...
Although the primary endpoint is motor response in the cranial nerve territory, any peripheral response to supraorbital stimulation should also be assumed to be a brain-mediated reaction. Some clinicians will also apply a peripheral painful stimulus, for example, to a nail bed,
Just a little bit of pushing on your finger now.
again looking for a central motor response. If there is an isolated peripheral response to peripheral stimulation, this should be regarded as a local spinal reflex that does not invalidate the diagnosis of death.
No reaction.
No reaction.
Next, we look for reflex activity from the lower brainstem by attempting to elicit a cough and a gag reflex.
Best expose his chest and abdomen.
We use a full-length endotracheal suction catheter to attempt to trigger a cough reflex by stimulating the carina.
And there's no cough reflex there.
No.
And we use a Yanker sucker to stimulate both sides of the pharynx to attempt to elicit a gag reflex. Note that some doctors will perform this under direct vision using a laryngoscope,
Visualize the
although
material
there's no
down to
absolute
your wall
requirement for
and
this.
uvula using a laryngoscope, and then stimulate each side in turn.
I can see no gag in his throat either from externally. Thank you.
We now move on to the oculovestibular reflex, which is sometimes referred to as the cold caloric response because it involves irrigating the tympanic membranes with ice-cold
Should we just
fluid.
look inside his ear, make sure there's no wax?
We start by examining the external auditory canals with an otoscope to ensure a clear access to the tympanic
There's no
membranes.
perforation of the eardrum.
Next, the head should be flexed to 30 degrees to the horizontal, and 50 ml of ice-cold water or saline should be injected through a quill into the external auditory canal over a minute. The eyes are held open during the irrigation, with both doctors looking for any sign of eye
There's
movement.
no reaction at all. I'm sorry, sir.
The final element of the examination is the apnea test. Is the patient able to breathe when taken off the ventilator and exposed to an adequate respiratory acidosis? This test should only be performed after all other brainstem reflexes have been shown to be absent. This is to avoid exposing the patient to what might be potentially harmful hypercarbia and hemodynamic instability should there be any residual brainstem function. The aim of the apnea test is to expose the patient to an adequate respiratory acidosis, that is, an adequate stimulus to breathe during a 5-minute period of disconnection from the ventilator in as controlled a fashion as possible.
Just the ventilator, please, so that is receiving 100% oxygen.
To help ensure this, before disconnection from the ventilator, we ensure that the patient is cardiovascularly stable. We pre-oxygenate the patient.
Take his minute ventilation down by reducing his rate to 15.
And we reduce the minute ventilation delivered by the ventilator to allow a mild respiratory acidosis to be reached before disconnection.
What's the PCO2?
CO2 of 6.
6.0. So it's going to be greater than or equal to 6.0, it is.
The patient is disconnected from the ventilator when an arterial blood gas shows that the arterial CO2 is equal to or greater than 6 kilopascals and that the blood pH is below 7.4. Although the CO2 may need to be higher in patients with chronic CO2 retention or in those who have received recent intravenous bicarbonate therapy. It is important that the patient is actually disconnected from the ventilator in order to avoid cardiac pulsations from triggering ventilator-assisted breaths or respiration being resumed by the ventilator's apneic mode.
Uncover you again, sir.
The patient is exposed down to the umbilicus. It is important that you are able to see the abdomen as well as the chest, and observed for a minimum of 5 minutes for any sign of respiratory movement.
Okay, do you mind switching the ventilator off?
The use of a respiratory monitor and end-tidal CO2 monitor may be helpful. During disconnection, oxygenation is maintained by using a Maplesome C circuit with CPAP, which will help prevent atelectasis and allow any patient breaths to be easily observed. Alternatively, you can insufflate with oxygen at 5 litres per minute down a suction catheter placed in the endotracheal tube. However, it is important to avoid high oxygen flow rates because this might wash out carbon dioxide. It is not uncommon to observe abdominal pulsations from the aorta during the test, and this can be confirmed by timing the pulsations with the ECG monitor.
No movement.
After 5 minutes of apnea, another arterial blood gas sample is taken to confirm that the CO2 is increased by at least 0.5 kilopascals and that the pH has fallen still further.
0.5, it's risen by minimum 0.5, so 7.3.
At the end of the apnea test, a recruitment maneuver should be performed before the patient is reconnected to the ventilator. Gas exchange should be allowed to return to baseline in preparation for the second set of tests.
Alex, are you satisfied the death's been confirmed following the irreversible cessation of brainstem function?
I am, yes.
Death is diagnosed and confirmed after 2 sets of tests demonstrate the complete absence of brainstem function, because we can now be confident that the patient has lost the capacity for consciousness and respiration, and that, on the basis of the assessments carried out in stage 1, that this is irreversible.
Moving on from the neurological death tests themselves and then bridging into organ donation can be quite difficult, and it's very patient family dependent. One of the things we would always do is advocate for a planned collaborative approach. So we advise that having the bedside nurse present, because the bedside nurse has often gathered information about dynamics of the family and already has started to build a rapport with that family. The consultant, obviously, is the clinician providing the care, and the specialist nurse for organ donation also to be present. We do know through our research that if one of the organ donation team are there and present for the approach to the family, that the chances are the consent rate is always higher. It's really important, though, when we go in to speak to a family, that we recognise that it's the right time for this family. So if you have a family that is still questioning the prognosis and the diagnosis of what's happened, but my mum's going to be okay, isn't she? She's going to get better. They're simply not ready to hear the words organ donation, and we need to spend some more time with them about that. If they're desperately trying to arrange childcare for the school run, if the dog hasn't been fed, sometimes it's just about making sure that we've done what we can to support other parts of their life and what's going on, so that when it comes to sitting down and having this important conversation, we know we've got their focus for that. And we would always promote the fact that this is a very positive act of giving, and that no families that I'm aware of anyway have ever regretted saying no to organ donation. But I do know families that have regretted saying, none that have regretted saying yes. I've had families regret saying no. So it's really important to do what we can to support their decision making. And we also need to consider whose decision is it for donation to go ahead. So if the patient was on our organ donor register, they'd opted in to say they wanted to donate, or they had spoken to their family and said they wanted to be a donor, then we would class that as first person consent. For those who've not registered a decision, either on the ODR, on the organ donor register, or with discussions with their family, if they meet the criteria, then we would deem their consent. So we had new legislation started in England in May 2020, following from what Wales had done before that, and Scotland had just done the same. That would mean we've moved to what we call an opt-out system. So should you not want to be a donor, then you're advised to make that decision known to your family and to go onto the organ donor register and opt out. So if they haven't opted out and they haven't opted in and they meet the criteria, it's deemed that they have no objection to donation going ahead, and therefore we can go down the deemed consent route. And for anyone who hasn't made their wishes known, who doesn't fit the criteria for deemed consent, then it's simply down to the family to make that final decision. And I have a little slide that shows us a little bit more about the legislation with the deemed consent. So it only applies to adults. So if it was, if we were talking about a child of 12 years, then it would be that third option at the bottom about the family deciding. So only applies to adults who die in England, and they need to have been resident in England for the full 12 months prior to their death. It doesn't apply to anyone who's under 18, to anyone who would have lacked the mental capacity to understand the new arrangements, the legislation, and to take the necessary action to opt out should they wish to. They weren't ordinarily resident for the full 12 months, or if they've already made a donation decision, whether that's to donate or not to donate, then that wouldn't apply to them either. I have one final video to share with you, and this is a very inspiring story of Ari and his parents.
He taught us how to be better human beings. He was only here for 3.5 years, but I can truly tell you that he achieved more in his life than I think Sian and I can ever achieve in ours. I took the instant decision and said, please save every single organ you can. Allow us to donate his organs to other needed children. I don't think the consultant or the nurse expected that.
I didn't feel at any point any pressure to have to do it, and I felt I could change my mind.
The nicest thing about that time was they gave us 24 hours more with Ari. This is Ari's life, this wasn't our life to give. I kept on saying, tell us what you want to do, Ari. And maybe this was his way of telling us that, you know, I've tried. And it wasn't enough. So I think we've done the right thing.
I didn't realise how rare it is for children to donate their organs. I thought it was quite a normal thing to do.
It's important that people think about decisions in a logical way, and that's why it was so easy, because it was really about Ari and what Ari would do to give back to others. His twin sisters have donor cards, and they're proud of having them. We have a lot of amazing videos, memories, photos of him, but this one thing I think helps us heal. It helps us believe that Ari's life wasn't wasted. While we lost our little boy, he donated his organs and we were proud of that. And Ari, I'm sure, lives on in others. Maybe the girl that has his heart has the same smile.
And finally, there's just a few links on there that gives you some other information. The videos that I showed earlier are from the ODT website at the top. There is the article written by somebody from India. There is where you will find our neurological death tests. And the Wales Online article at the bottom is the article about the 18-year-old who woke after having his tests done last year. And if all has gone well, it means that the presentation's worked and I am now available live to answer any of your questions. Thank you.
If anybody does have any questions before we finish, please do send them in. +44 333 303 0975, or you can visit our Facebook page, www.facebook.com/SVJCUK. And we really do want your feedback. Please scan that QR code on the screen and send us your feedback. It really does help us. But for now, I'll hang on a couple of minutes, and if there's no questions, then we will say thank you very much for listening. Remember, you can review this presentation at any time on YouTube. The best way is to go to our Facebook page.